Hello, everyone. Good afternoon, good morning, depending on which time zone you're in. We are super happy you're here with us today for this webinar. My name is Angela Craig, and I will be the moderator for this webinar. I am a medical science liaison with Baxter. Today, we are going to hear the topic From Fear to Fluid, Developing a Stroke Volume Guided Sepsis Program. Tami Garcia, Sepsis Team Manager of Michigan Medicine, and Rose Mulcahy, Adult Inpatient Sepsis Coordinator, will be presenting this for us today. We would love some participation, so we ask that if you have any questions, please put that in the Q&A tab, and there's a visual there on your screen which will show you exactly how to do that. We also would appreciate it if you would please participate and fill out the survey. There will be a QR code at the end of this webinar. It really helps us to see what it is that you guys would like and what topics are important to you. So we take this very seriously. So please fill that out for us. And without further ado, I will hand it over to the Michigan Medicine ladies.
Thank you, Angela, for that introduction, and welcome everybody. Thank you for having us here today to have us share our story. I'm Tami Garcia, as Angela said, and I'm joined by my colleague, Rose Mulcahy. And just to start, our disclosure is that we are being paid for this presentation by Baxter. Today, our learning objectives include the data that we use to target our interventions, the steps that we took to develop our stroke volume guided sepsis program, and we are going to end with a patient success story and improved outcomes from the program implementation. So to begin, we may ask, why sepsis? Sepsis is common. It accounts for approximately 1.7 million hospitalizations annually, more than heart attack and stroke combined. Sepsis is deadly. 350,000 deaths are attributed to sepsis annually, accounting for 33 to 50% of all hospital deaths. Sepsis is costly. It is the most costly cause of hospitalization. In 2020, it cost $38 billion. Along with being a major driver of mortality, sepsis also contributes to morbidity. Only 55% of previously employed patients returned to work within 6 months due to a threefold increase in moderate to severe cognitive impairment and 1 to 2 new functional limitations to their activities of daily living. There is also an increased risk for readmission and hospitalization. Half of patients live with psychological symptoms such as depression and/or fatigue, and there is an increased risk in post-acute mortality. Just as a refresher, let's talk about some sepsis definitions. First, let's think about SIRS, or Systemic Inflammatory Response Syndrome, which is an exaggerated response to a stressor such as an infection. To the right is the sepsis badge buddy that we give to staff at Michigan Medicine with the SIRS criteria from the SEP1 definition. The SIRS criteria include heart rate greater than 90, respiratory rate greater than 20, temperature less than 36 degrees Celsius or greater than 38 degrees Celsius, and white blood count less than 4,000 or greater than 12,000. So what is sepsis? It is a suspected or confirmed infection plus 2 or more SIRS criteria. Next, we have severe sepsis, which is sepsis with at least one new organ dysfunction. So let's look again at the badge buddy for those criteria. New change in mental status, lactate greater than 2, systolic blood pressure less than 90 or 40 decreased from baseline, or your MAP less than 60. New O2 requirements, or an SaO2 less than 90%, creatinine greater than 2 or an increase from baseline, total bilirubin greater than 2, platelets less than 100,000, INR greater than 1.5, or urine output less than 0.5 mLs per kg per hour for 2 hours. Last is septic shock, which is a life-threatening condition involving an overwhelming response to infection causing persistent hypotension and or a metabolic derangement as evidenced by a lactic acid greater than or equal to 4 after receiving a 30 ml per kg IV fluid bolus. Just remember that the presence of SIRS doesn't necessarily mean sepsis. It means to pause and ask, could this be sepsis? Now, just pulling it all together, let's review this visual trajectory of sepsis. First, we start with an infection causing a systemic inflammatory response, also known as SIRS. The criteria is also to the right. With 2 or more SIRS plus an infection, we have sepsis. If there is a new organ dysfunction plus sepsis, we have severe sepsis. And finally, if it progresses to septic shock, we have severe sepsis plus a lactate greater than or equal to 4 and or persistent hypotension after receiving the 30 ml per kg IV fluid bolus. So now let's discuss some sepsis basics that we can think about. What do we need to do? Use the SEP1 bundle of care. This is evidence-based care supported by Surviving Sepsis campaign. We know from research that every hour we delay appropriate antibiotic therapy, the result is an 8% increased risk of mortality. So let's look at the bundles. What is the bundle? The 3-hour bundle is where we get a stat lactic acid level. We think about giving, we draw blood cultures prior to our antibiotic administration. We give broad spectrum antibiotics, plus we give a fluid bolus if the patient is hypotensive and or has a lactate greater than or equal to 4. The 6-hour bundle includes a repeat lactate if the initial one was greater than 2, the checking of 2 blood pressures within 1 hour after the fluid bolus is complete, vasopressors for persistent hypotension, and provider documentation for the reassessment of volume status and tissue perfusion. Many times we encounter skepticism when we discuss the SEP1 bundle. So does the SEP1 bundle work? According to the literature, even when bundle compliance rates of less than 30%, absolute reductions in mortality of 4 to 6% have been noted. Absolute reductions in mortality of over 20% have been seen with bundle compliance rate of 52%. And when all bundle elements are completed and compared to patients who do not have bundle completion, the mortality difference is 14%. So in conclusion, there is a direct association between bundle compliance and improved mortality. Now we're going to discuss our fluid journey. Let's start with the why. From January 1, 2021 to December 31st, 2021, 546 adult patients died due to sepsis at Michigan Medicine. This does not include those who were discharged from the hospital to hospice. Our team, shown on this slide, was formed in March of 2022 because sepsis is our highest volume DRG outside of deliveries and births, and there were no clearly defined clinical or operational owners of sepsis care, like stroke and MI. Moreover, sepsis is the largest driver of our hospital mortality. Sepsis recognition is poor with a lack of specialized testing like EKG or CT scanning. Sepsis is not treated like the medical emergency that it is, and knowledge of the sepsis bundles is poor. Finally, Michigan Medicine has its own internal data to support that bundle compliance rate reduces mortality and length of stay. When we review our internal data of severe sepsis in septic shock patients, we found that 35% of non-compliance came from lack of fluid resuscitation. The pie chart shows that 52% of the patients required fluids. Of those, 24% did not get any fluids. Only 22% got the full 30 ml per kg IV fluid bolus. The patients who received fluids were only getting a 500 cc bolus. Michigan Medicine was found to be hydrophobic. So we did a Gemba walk. We conducted a root cause analysis by collaborating with ICU teams to understand their sepsis care process and barriers. Rose and I engaged in humble inquiry using jam boards and sticky notes to capture their feedback on fluid administration challenges. We organized this information into themes and created a fishbone diagram to visualize the barriers. Our analysis revealed widespread myths and fears about fluid administration harming patients. We want to take a quick second to thank the Michigan medicine teams for their partnership, as their input was crucial to this effort's success. Those teams included our ICU teams on 4D, 5D, 6D, and 8D. And then we'd also like to thank Dr. Elizabeth Monroe, as she's been a vital part of this implementation and education to teams and slide creation. So when we looked at the work that we did during our Gemba, we had to address our sepsis management gaps and required some targeted actions. The first gap lies in recognizing sepsis and ordering fluids. Often due to recognition failures or reluctance to give fluids. To address this, we can use sepsis order sets to fill knowledge gaps and non-invasive cardiac output monitoring, or NICOM, technology to reduce fears about fluid administration, alongside improved education for better sepsis recognition. The second gap between ordering and initiating fluids shows minimal delays. The third gap concerns patients not receiving the full fluid volume within the recommended time. Missing the 3 or 12-hour targets may stem from knowledge gaps or unnecessary fear of fluid overload. These can be mitigated with NICOM and order sets. If fluids are given within 12 hours, but not within 3 hours, we should assess and address barriers in the fluid ordering or initiation process, utilizing provider-focused order sets or nursing interventions where necessary. To bridge this gap, we needed to consider the fluid bolus ordered through the recognition of sepsis and ordering fluids, and target volume, giving enough fluid within the target time frame, the 30 ml per kg in 3 hours. Now I'd like to have Rose jump in, and she will continue us on our fluid journey.
Thank you, Tami. There are probably many solutions to bridge this fluid gap, but the two I will focus on can help providers make decisions about giving fluids. Our order sets that guide providers to order the appropriate amount of fluids, and they can improve their documentation as well. Our institution uses Epic. And then tools that help clinicians make decisions about giving fluids, and I will then specifically speak about the NICOM. We developed 2 order sets, one for the inpatient and another for our critical care teams. I worked closely with antibiotic stewardship and providers to learn their needs to complete a comprehensive order set. We have smart logic for our blood cultures, the pull on the site, and the cultures if they were drawn within the last 24 hours. For our fluids, any fluid order that has been running greater than 125 mLs in the prior 6 hours will be reflected so the provider knows how much fluid has already been given. When the clinician clicks to order the 30 ml per kg fluids, the order set will auto-adjust to recorded if the BMI is less than 30, and it will auto-adjust to ideal body weight if the patient's body mass index is greater than 30. We have aligned our order sets to meet Step 1 compliance, and the screen tells the provider how much fluid the patient requires, and they can then subtract this from the total amount the patient may have already received during the prior 6 hours of hypotension. We created dot phrases to improve our documentation compliance based on CMS requirements. We have a dot sepsis fluids dot phrase that will address if the provider determines the patient needs an alternate fluid volume other than 30 mLs. And then we have a dot sepsis perfusion that is to be used after the bolus for the provider to document their post-perfusion reassessment. I created flyers and handouts that are posted in each of our workrooms throughout the hospital, encouraging providers to use the order sets and dot phrases. So how much fluid should we be giving our patients? And how do we know how much? We recommend looking at the current guidelines and evidence and use physiology-based tools to assess fluid responsiveness to give targeted fluid resuscitation. This 30 ml per kg fluid bolus in the treatment bundle comes from the Surviving Sepsis Campaign guidelines, which say for a patient with a sepsis-induced hypoperfusion, they're not perfusing their organs, it is suggested to give 30 ml per kg IV crystalloid fluid within 3 hours of resuscitation. There are currently no randomized control trials defining the optimal fluid volumes for sepsis treatment. There are no head-to-head trials stating that 30 mLs is better than 25 or better than 20. However, high-quality retrospective studies like this one from Kaiser Permanente with over 9,000 adults show that giving 30 ml per kg of fluids is associated with decreased mortality. The study found that administering between 15 to 45 mLs per kg of fluids correlated with improved outcomes, while less than 15 ml per kg or more than 45 ml per kg were linked to higher mortality rates. This other graph is from a retrospective analysis across 612 U.S. hospitals looking at over 190,000 sepsis and septic shock patients. The study revealed a wide variation of IV fluid volume due to individual physician practice within each hospital rather than between hospitals. They did find that when patients received between 2.5 to 5 liters of IV fluid, their mortality was lower. Both studies highlight that giving too little or too much fluid results in higher mortality, emphasizing the importance of aiming for 30 ml per kg fluid resuscitation and adjusting the volume for a more tailored approach. This is what the FRESH trial intervention looks like. This algorithm looks complicated, but is rather simple when you break it down. When the patient is showing signs of hypoperfusion and meets the above criteria, then perform a passive leg raise or a PLR. If the stroke volume changes less than 10%, they're probably not fluid responsive, so consider vasopressors. If the stroke volume increases more than 10%, then they will benefit from fluid, so give a bolus and reassess. If the patient keeps responding to fluid, then keep giving fluid per the algorithm and reassessing until they are either no longer fluid responsive or they have received a total of 2 liters. For patients with septic shock in the ICU, guiding fluids by serial assessments of stroke volume responsiveness using NICOM may improve outcomes. The results from this study led to decreased dialysis by 12%. Below in the red was the intervention, and blue is the usual care. Intubation decreased by 16%, and 20% more patients were discharged home. This was a small study with big impacts. By using this physiology-based approach to giving fluids, improved outcomes for these patients. How can we determine stroke volume? We now have a non-invasive tools to determine stroke volume. Looking at the bottom left image, there are 4 patches that can be applied to the patient's thorax or back. These patches use bioreactance technology, which measures the flow of blood in the thorax and produces a time delay or a phase shift. This phase shift is tightly correlated with stroke volume. We can then perform a dynamic assessment which challenges the heart with a small amount of fluid to gauge its response. And there are 2 ways to perform this dynamic assessment, either with a fluid bolus or with a passive leg raise. The patient starts by laying flat. Then the healthcare provider passively lifts their legs to a 45-degree angle, which translocates the blood from their legs to their heart. The blood in their legs equates to about 250 to 300 ml bolus. Then we assess how their stroke volume responds. In a patient who is preload dependent, meaning their heart needs the fluid, that's in the teal, and when you give the fluid challenge, their stroke volume is going to go up, indicating greater than 10% change. Their heart is like, it likes the fluids. It'll say, great, I'm going to squeeze better. When the patient is preload independent, shown in gold, and you give the same volume of fluids to the patient, their stroke volume will reflect a less than 10% change, as they are at the top of the Frank-Starling curve, and they are deemed to not be fluid responsive. This NICOM bedside device is nice because it can help us determine fluid responsiveness non-invasively. Introducing this device to our hospital took some planning. I meet monthly with our critical care committee, which comprises of ICU physicians, pharmacy, nurses, and rapid response team nurses. The team walked the committee through an A3, which is a collaborative process to identify problems, root causes, and identify solutions. From this process with our frontline staff and from the work Tami described earlier, we determined there was a fear of harming our patients by giving them too much fluids. We provided research and the data that fluids are beneficial when given in the right amount. Our internal hospital data supports that when we give IV fluids to our congestive heart failure and chronic kidney disease patients, their mortality is lower. We educated teams about sepsis and the SEP1 bundle of care, but despite the studies and our education, teams continued to remain hydrophobic. We then introduced the NICOM technology. We created a business case and submitted an SBAR to hospital leadership. We modeled our fluid administration algorithm after the FRESH trial. Super users were identified and training was planned for staff rollout of the technology. All staff were educated prior to the go-live. Monitors and supplies were dispatched to the units and integrated with Epic. We attached the algorithm and user tools to each machine. Super users were scheduled on all shifts. The NICOM tech support was available 24/7 for the go-live. We rolled out the NICOM devices early March 2024 in our medical and surgical ICUs. We doubled our NICOM usage every month and collectively used the device on 78 patients by July. Then in July, we expanded to our neuro and pulmonary ICU. The usage continued to increase, and by December, we used the device on 221 patients. 23 of those were in our neuro ICU. Our sepsis team was formed March of 2022. By 2023, we began to see an impact on our sepsis mortality. This is not risk adjusted. Our overall hospital length of stay remained constant at 19 days, but by 2023, we began to see improvements from 19 days to 17.4, and more recently to 15.7 days. We implemented the NICOM in 4 out of 7 ICUs in 2024, and you could see our ICU length of stay begins to see a dramatic decrease by 2024 when comparing on average 12 to 13 days, then after our program formed to 9.9 days. In 2024, we implemented the NICOM and our ICU length of stay decreased to 8.6 days. After calculating our raw risk-adjusted mortality and then comparing 2020 to 2024 data, this equates to 149 severe sepsis septic shock lives saved. Our CMS compliance numbers have also made a dramatic improvement from 2020, where we were at 28.6% compliant, to now 2024, where we are near meeting national standards at 55%. So let's switch gears and see how this NICOM device is applied to our patient case. We have a 67-year-old woman with a history of type 2 diabetes, hypertension, and chronic kidney disease. She presented to the ED after being found down in the setting of hypoglycemia, and she was admitted to the general medicine. Hospital course has been complicated by acute kidney injury that worsened despite IV fluid administration earlier in her admission with ongoing difficulty with blood sugar control. On hospital day 10, the patient develops a new oxygen requirement and fever. A rapid response is called for hypoxia. This is the data from the rapid response. She is satting 90% on 15 liters non-rebreather. Temp is 38.5 or 101.3. She's tachycardic at 115, tachypneic 25, and her leukocytes jumped from 10 to 15, and her lactic acid resulted in 3.2. Her baseline creatinine elevated, and we're not sure what her urine output was as it wasn't being recorded on the floor. Her chest x-ray shows these focal right upper lobe opacities, which are highly concerning for her new pneumonia in this setting. She's sent to the ICU for her hypoxia, but on arrival to the ICU, her blood pressure dropped to 75/45 and was persistently low on a repeat check. So at this point, the team recognizes she has severe sepsis. Our patient has a fever, her white count is 15, she's tachypnic and tachycardic. She has all 4 SIRS. We have evidence of pneumonia on her chest x-ray, and she now has the following 4 organ dysfunctions: hypoxia, hypotension, elevated lactate, and acute kidney injury. She's not perfusing her organs in the setting of severe sepsis. She certainly qualifies for a weight-based IV fluid bolus because of her hypotension, but the team is worried about giving fluids to this patient. So how do we decide how much to give? Well, first, we look at the guidelines and evidence. The Surviving Sepsis Campaign guidelines suggest giving 30 ml per kg bolus for sepsis-induced hypoperfusion or septic shock and should be given within 3 hours of resuscitation. Providers are hesitant to give fluids to patients with a history of heart or kidney failure. The team's hesitation with this patient is not wrong to question if she should get the full 30 ml per kg fluids. She has chronic kidney disease, the floor hasn't been keeping accurate I's and O's, and she's now on 15 liters non-rebreather. And that's where these physiology-based tools come in to assess dynamic fluid responsiveness in our patients. This allows us to accurately measure the patient's fluid status. Will giving fluids help this patient increase her cardiac output to perfuse her organs better? The team doesn't want to give any fluids to this patient, so we suggest trying the NICOM to test fluid responsiveness. We took the FRESH trial protocol that I walked through earlier, and you will see how we modeled ours to look very similar to help guide fluid resuscitation based on stroke volume change for our teams. This device is not only used for initiation in the beginning stages of sepsis, but it can also be used when pressors are increasing or decreasing. It should remain on the patient to provide non-invasive hemodynamic information. This is what her monitor screen looks like with her initial measurements. Just by placing the stickers on the chest, we non-invasively capture her stroke volume index, which for her are normal, her cardiac output, cardiac index, which for her are elevated, consistent with septic shock, her total peripheral resistance, excuse me, which tells me what her blood vessels are doing. Are they leaky and dilated, or are they squeezing? And total peripheral resistance index. She has a high cardiac output. Normal is 4 to 8, and hers is 9.5. Total peripheral resistance, normal is 800 to 1,000, and hers is 496, indicating her vascular resistance is too low. This is a very clear picture of septic shock. The bottom half of the monitor reflects her passive leg raise and what happened to her stroke volume. Her stroke volume went up 23%, which shows she was fluid responsive. This has given us a window into what is happening in real time to the patient's heart when we're giving them fluids. This gives us a lot of information non-invasively about how to administer fluids, when to give more, and when to stop. For this patient, the plan was to give her no fluids. We decided to put the NICOM on her, and she ended up going through the cycle 3 times, and all 3 times she was fluid responsive. She received a total of 2 liters of IV fluid based on those repeated measurements. With that, her blood pressure stabilized and she did not need vasopressors. We were worried about her oxygen status because she was already on 15 liters non-rebreather, but her O2 requirements improved and she was decreased from 70% to 50%. This tool really allowed us to identify this patient who we already had concerns about giving fluids to. Some concerns were valid with her hypoxia and some were not so valid with her kidney failure. It helped us to keep her out of trouble and give her the fluid resuscitation she needed. In conclusion, our approach ensures optimal fluid resuscitation for patients through a structured strategy, administering an initial 30 ml per kg IV fluid bolus, using sepsis order sets for accurate volume calculation, and leveraging dot phrases documentation for enhanced accuracy. Importantly, patients with a history of heart or renal failure are not adversely affected by this protocol. The integration of NICOM is an objective assessment tool that empowers clinicians to make informed decisions for both initial and ongoing fluid management, ultimately improving patient outcomes. As we look to the future, our focus will be on continuing to work with teams to sustain the education and proper use of this device across our ICUs. We'll also be expanding its application to additional ICUs and our rapid response team on general care units. By standardizing care, we will ensure the sustainment of both the technology and education required for its success. We want to thank you all for your time and attention today, and at this time, I'll pass it back to Angela.
Thank you so much, you guys, for sharing your expertise and sharing your information. We do want to thank everyone for joining, and this is the QR code that will allow you to scan and give us your evaluation of this program. Next slide. I also just want to let you know that we do have a fluid management website, and the fluid management website is Fluid Management Education. There we go, fluidmanagementeducation.com. You do have a QR code there that you're able to review, or you can go to fluidmanagementeducation.com. Next slide. And now we just want to take a few minutes for some questions that you maybe have had throughout this talk. Thanks, you guys, for presenting. I think the first question I would just say is, were there a lot of barriers as you were rolling out this protocol? Were nurses nervous? Were doctors nervous? Or did everything just go smoothly and they just trusted you?
We wish it all went smoothly, but no. Yes, with any rollout, there's definitely some barriers, a lot of distrust. The barriers that we most frequently encountered were nurses were fearful that the machine was going to tell them the wrong thing and they were actually going to harm their patients. So how we overcame that was we would learn from the cases where we did trust in this, such as in this case, where the nurses were hesitant, so was the physician teams, and rightfully so, that they were fearful that they would have to intubate the patient. And this one had a positive outcome, so we would share cases such as this one where we had positive outcomes. We did not have any adverse cases, and so the teams, while sharing these stories, having staff talk about them, has helped us overcome some of that hesitation and increase our usage.
For sure.
And I'll just add to that too, Angela and Rose, that we had some physicians that were really not wanting the technology and not believing in it. And so then after we rolled out the technology, we were rounding and we ran into one of those physician partners that was not a believer. So we just, humbly inquired, how is it going? How is the use of technology? And he kind of smiled, and then he had to kind of say, yep, I use it on patients and it changed my clinical decision making. And then we heard after that, then when this provider was on, that they were using the technology with most of their patients, not even if they weren't septic, they were just trying to look at fluid volume status. So he truly changed his practice with use and then finding out the value of the patient outcomes.
Yeah, that's great. That's a great, and I think the point is here, we just really need to share data, also have people experience it so that you know what you're looking at and that you can understand the technology better. That's amazing. One of the questions that came in the chat was, how important was the mortality consideration for the team when deciding to implement this approach? One thing before you answer, I just want to applaud you because you've been very data driven. And so you really looked at your numbers before and you've been evaluating them all throughout. I'm of the personal opinion, if you're not looking at data for something, you're not not data driven if you're not really looking at this certain data points. So how would you say that mortality data really helped you with this decision?
Yeah, I can answer that. I think when we first started this work, we were hearing a lot about SEP 1. It was going to become, pay per performance. And we started that direction. And then really when we step back to think about why are we doing this work? Why is it important? And then really looking at those lives that were being lost due to sepsis and our lack of, recognition and early treatment, then we started to refocus and looking at what is the mortality and really how many patients are dying because of sepsis, who could we prevent from dying, because some patients are really sick and not preventable. And then really looking at after the rollout of our work, not only with this technology, but just in sepsis recognition and education, looking at those decrease in mortality and showing this is the actual number of people that you've saved that are going home to their moms, to their dads, to their children, to their grandchildren, to their friends and family, which really makes it the most impactful. That's why we're all here.
Absolutely. It's really all about the patient. That is excellent. Another question came in, said, do you run into the patient being fluid responsive after the initial 30 ml per kg and still hypotensive where a little more fluid is given and pressors didn't have to be started at all?
Yes, it does happen. So I have seen where patients have gotten the full resuscitative bolus, and then they go to the ICU, and then they'll have the machine applied, and then they need additional IV fluids. And the patients, I'll never forget this one. She had the full resuscitative bolus. Our RT was at the bedside. The patient did not look good. She was in reverse Trendelenburg. They got her to the unit. They gave her additional IV fluids, and she never needed pressors. And then she was sitting up in bed talking and laughing on the phone with her family member, and it was really wonderful to see.
That's amazing.
So
that's always great.
Made a full recovery.
Yeah. Excellent. Excellent. Somebody has also asked, this as a compliment to you guys, would you be able to share the order sets? This person said they're transitioning to Epic this year. Is that something that you're able to potentially share? Or if you send them to me, I can share with the people on this call?
Oh, certainly. I'll take, yes, I'll send the screenshots. Be happy to.
Okay. Awesome. We got a comment that says our rapid response team utilizes it outside of the ICU very well. Is that something that you guys are thinking about doing with rapid response?
Yes, that's something we're currently exploring, how we can have the rapid response team operationalize it, be on the go. We have multiple hospitals and they use the stairs. So we're exploring how we can make this work for our teams, and we're looking to roll that out later this fall.
That's great. I have heard of some places as well starting to utilize it in the emergency department. And I know that's not happening yet at U of M. Maybe at some point it might, but great opportunity to get fluids right from the beginning, right? Since such a large percentage of patients come in through the emergency department for sepsis, this may be something to potentially explore. Do you have any thoughts about that?
Yeah, we do. Actually, when we originally rolled out this technology, we had offered it to our emergency department, but with all the competing priorities and high volume, it just was not something they thought that they could consider. But yes, we actually had Dr. Monroe had presented an M&M similar case, use of NICOM, had ED nurses and providers on, and they were all raising their hand to ask about it. So now we have sparked some interest, and we've started some conversation. We're just not sure, when is going to be the timing of that, the best timing of that, and when and how we can operationalize that.
Yeah, that's a lot to think about and a big undertaking, especially for such a large emergency department as you all have. But I think we've really covered a lot of the questions. You guys have been great just to share your story. And I think I just applaud you for sharing your story and for all the hard work for this sepsis patient population. And I'm just grateful that you're here with us. So thank you so much. And we are going to conclude.
Thank you.
Thank you.